It's September 27th, 2024, and this is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. This week, we have a rich podcast, lots of stuff, some new top-line results of trials in development in lupus, some new regulatory approvals, but let's begin with an announcement. Fanfare, drum roll. That's right. RheumNow Live is now live as far as registration. RheumNow Live 2025 is going to be held in Dallas on February 8th and 9th, Saturday, half day Sunday. You want to be there, you can register at RheumNow.live. Great rheumatologists like you deserve a phenomenal meeting like this. Let's begin with lupus. We discussed that before. UCB and Biogen have been working on the development of an anti-CD40 ligand monoclonal antibody called dapirolizumab. They did a phase 2 trial, which didn't quite look so good, but the results of a phase 3 that they announced this week, at least the top line results, the study was called the Phoenix Go study, a 48-week study of lupus patients with moderate to severe disease who are on standard of care therapy, who receive either dapirolizumab or placebo. And yes, those on the biologic had significant improvement in their BILAG scores at week 48. And I assume we're going to hear the results of this trial coming up at ACR 2024 in maybe 6-7 weeks from now. By the way, ACR abstracts are now available if you want to go on the ACR website and start searching for your favorite topics and maybe advances in your topic area. Another new top-line announcement came from Genentech this week. The results of the Regency Phase 3 trial using the other anti-CD20 monoclonal antibody. The industry standard in oncology is not rituximab. It is obinutuzumab, also marketed as Gazyva. I like obinutuzumab. They have a phase 3 trial in lupus nephritis with a 76-week endpoint of complete renal response. They enrolled patients with biopsy-proven lupus nephritis, either class 3 or class 4 proliferative disease with or without membranous disease. All patients were taking a background of mycophenolate and steroids, and they were either given placebo or the obinutuzumab for 76 weeks. And by the primary endpoint and secondary endpoints, obinutuzumab was superior to placebo with a background of standard of care. I think this is a major milestone. Those who treat lupus, those who like the development of trials going on, are really looking forward to this drug. And I think this is good news for all of us, especially those of us who are worrying about and treating lupus actively, especially more aggressive cases. And this is a lupus nephritis case. I found another great report this week in Nature discussing considerations on how to treat lupus nephritis, and while it focused on the usual things, control of inflammation and lupus activity through all the things that things I just mentioned, for instance, they really made a big point about non-immune factors, some of which are modifiable factors, some of which are not, that significantly contribute to CKD. The point of this paper was, if you've got lupus nephritis, you have chronic kidney disease. And the question is, how are you going to minimize that? Obviously, treating lupus aggressively. But paying attention to the non-immune factors, obesity, hypertension, salt intake, protein, high protein diets, diabetes, pregnancy, smoking, and nephrotoxic medications all will contribute to the advance in CKD in patients with lupus and lupus nephritis. They make a big pitch for the use of renin-angiotensin inhibitors and possibly the SGLT2 anti-diabetes drugs in patients with lupus who have proteinuria and who have either decreasing GFR or a very low GFR. The data looks good for those. So I like this as a perspective piece on how to best manage lupus nephritis. This week, the INVIGORATE-2 study was published. As you know, secukinumab was FDA approved and the IV form for the treatment of psoriatic arthritis. That was last August when I went to, or was it October, when I got the announcement on the day I went to my 50th high school reunion. I think the IV secukinumab news was better than the reunion, but that's another story that we can't go into here. Nonetheless, the Invigorate study basically showed that intravenous secukinumab is both effective in treating active psoriatic arthritis and showed improvements that were basically equivalent and what you would expect when it would be the drug would be given subcutaneously. So that is now in the literature and supports the data the FDA saw prior to you seeing it today. The other big announcement, regulatory announcement this week, was the FDA approval of bimekizumab, Bimzelx. It is a dual inhibitor of IL-17A and IL-17F, making it the fourth IL-17 inhibitor drug to market, this one being distinctive in that it is a dual inhibitor. And what that will mean, well, you're going to define that. The drug is interestingly approved for 3 chronic inflammatory conditions. As you know, bimekizumab was FDA approved in October of 2023 for use in patients with active, moderate, or severe plaque psoriasis, not responding to or needing more than conventional therapy. And its takeoff in the dermatology world has been very strong. We've been waiting for approval in the rheumatology world, and we got that this week with the approval of bimekizumab for active psoriatic arthritis, active ankylosing spondylitis, and active non-radiographic axial spondyloarthropathy. The dose here is different than the dosing used in treatment of the active psoriasis patients. Here it's 160 milligrams subcutaneous injection given every 4 weeks. They have a pre-filled syringe, they have an injector, and the approval is based on 2 big phase 3 trials in psoriatic arthritis, the B Optimal and the B Complete trial, and then 2 other big trials in the spondyloarthropathies, the Mobile 1, Mobile 2 trial. I think the one interesting takeaway on this approval is that the drug works equally well in patients who are biologic naive or those who are biologic experienced. I think that's going to be interesting to see how that affects your prescribing and treatment of those patients. Another interesting report this week comes in the journal Drug Safety, which is a report on the maternal exposure to upadacitinib during pregnancy. So this comes from 2 leaders at UCSF, Uma Mahadevan, who I talked about 2 weeks ago, and Leanne Gensler, but also Megan Klaus at Duke and Christina Chambers at UCSD, all very interested in pregnancy, and I applaud them for working with the manufacturer of upadacitinib to report on 128 cases with maternal exposure and known outcomes. 80 of these cases came from randomized clinical trials and 48 from post-marketing reports. The roughly 50% or more live births, 24 to 38% spontaneous abortions, 21 to 15% elective terminations, and no evidence of teratogenicity. So I think that's important that we don't need to freak out necessarily, but again, good pregnancy data, any pregnancy data is hard to find, and I guess that this data is probably going to have to be incorporated into the package insert information on upadacitinib. Another study this week on the incidence, 2 studies this week on the incidence and frequency of psoriatic arthritis. The Tudor study was reported in Rheum. It comes from the United Kingdom, where they actually followed longitudinally a primary care cohort with psoriasis. And then they looked at the incidence of PSA at 1 year and 2 year, and the incidence was roughly, it went up with more follow-up, and roughly the combined incidence was 2.2 cases per 100 patient years. This is supposedly higher than what's out there in the literature. And again, if you're a PSA geek, you're going to like this kind of information. Otherwise, you're wondering, why is he talking about this? Well, he's going to continue to talk about this because I got a Korean claims data report on the prevalence of psoriatic arthritis, showing that it actually increased from 2008 to 2020, when the prevalence went up from 6 cases to 19 cases per 1,000 patients in 2020. So the incidence of PSA also increased from 3 to 5 cases per 1,000 during the same era. Those numbers don't quite jive, but then again, the methodologies and how the data was arrived at are quite different. And that's why you're going to see spread when you're looking at epidemiologic data. Speaking of epidemiologic data, what about the risk of interstitial lung disease in patients with inflammatory arthritis? Well, who better than the Nordic registries, to put their data together with over 40,000 patients with either RA and PSA. Most of them were RA, compared to 362,000 population controls. The RA and PSA patients were on methotrexate or not, and were starting their first biologic DMARD. Incident ILD was not surprisingly higher in RA than in PSA, but compared to the general population, the risk of ILD in RA was almost 10-fold higher. That's kind of scary. But did you know that in PSA it would be 4-fold higher than the general population? I wasn't really aware of that, and maybe I need to be considering ILD more in PSA patients. The other interesting takeaway from this study was that methotrexate did not influence the risk of getting ILD, not in RA patients where the hazard ratio is 0.9 or in PSA where the hazard ratio is 1.0. So again, more evidence that's going to deeply and frustrate your pulmonary colleagues who are holding on to this belief that methotrexate causes ILD. No, methotrexate causes an acute hypersensitivity pneumonitis, and ILD is related to underlying inflammation and chronic inflammation and is very different in its pathology and outcomes, obviously. I have talked a lot in the past about depression as a complicating factor in rheumatic disease, especially in rheumatoid arthritis. A Danish study actually looked at loneliness, and I think that we're seeing data like this, that loneliness is a problem in our aging population in general. It can complicate the management of chronic inflammatory diseases. So in this study, they did a population cross-sectional survey, and they identified almost 13,000 inflammatory arthritis patients, RA, PSA, and SPA. And they found loneliness in about a third of the patients. It seemed to be highest in SPA patients with depression, where it was seen in 66%. It was seen clearly associated with disease activity. Patients with high disease activity, with especially RA and PSA, 50–60% had loneliness as a problem identified by the patient. You can imagine what that's going to do. It sets them up for depression. It sets them up for not doing well, not responding to medicines, not taking medicines. Identifying loneliness could be an important part of your assessment of patients with chronic inflammatory arthritis. Put up a few reports this week that got a lot of play, meaning you looked at these in great numbers. A JAMA report on the use of muscle relaxants to treat chronic pain. This is a systematic review that included 30 RCTs and 14 cohort studies, over 2,400 people that were treated with or not with a muscle relaxant, mainly for management of short-term pain. The trials were roughly 4 to 6 weeks. They looked at muscle relaxants, baclofen, tizanidine, and cyclobenzaprine made up the majority of these cases. They found strong evidence for their use in controlling pain in patients with trigeminal neuralgia, neck pain, and painful cramps. However, bad news, rheumatology, it was not any better than placebo in treating fibromyalgia, chronic low back pain, headache, or other pain syndromes. We often use it in those situations. 1, because we don't have many options. 2, because the patients are hard to treat. 3, because we don't want to use narcotics. So if you keep using them, then you're going to be paying no attention to the data, at least from a meta-analysis or systematic review. In a few years ago, I want to say 2 ACRs ago or 1 ACR ago, Alexander Oldroyd in Manchester had a plenary session talk about screening for cancer in dermatomyositis patients. He's part of a work group that's called the International Myositis Assessment and Clinical Studies Group, IMACS, and they developed a stratification system based on what features the patient presents with who has inflammatory myositis, or in this case that I'm going to talk about, dermatomyositis, that would classify them as being at high risk for cancer, intermediate risk, or low risk. So this was actually published already. It was published in, I want to say, in Nature, that the recommendations, and they said that if you were high risk, that you would undergo more testing, much more expensive and even more invasive. The high-risk group included those with dermatomyositis, antibodies against TIF1 gamma, NXP2. Those were over age 40 at the time of onset. Those with persistent high disease activity on immunosuppressive dysphagia or cutaneous ulcerations. The intermediate risk group were polymyositis, clinically amyopathic dermatomyositis, those who have necrotizing myositis, HMGCR antibodies, MDA5 antibodies, and being male. Anyway, so these criteria and risk stratification scheme was now being applied in the report that I listed this week. It came out in JAMA Dermatology just a few days ago. And what they applied this to a cohort of 370 dermatomyositis patients from the University of Pennsylvania. This is Victoria Wert's combined rheum derm clinic. 87% of the patients were female. 69% had available tests on myositis-specific autoantibodies. And they were, I think, 70+%. Their average age was 48 years, I believe. So they applied the risk stratification scheme developed by the IMACS group. 54% were high risk, 37% intermediate risk, and 9% were low risk. Overall, from the 370 patients, only 5% had a malignancy, 18 out of 370. Interestingly, all of those patients came from the high risk and intermediate risk group. So if you're a low risk group, no workup really should be necessary other than a good H&P and health maintenance screening. The question is more advanced screening appropriate? And I don't think that they met that mark here. So the interesting thing was the patients with paraneoplastic dermatomyositis, they call them, that 83% of them were in the high risk group. Maybe some worry there, but few came from the intermediate risk group and none from the low risk group. That the important thing about the utility of these recommendations is that while 90% of these patients were in the intermediate and high risk groups, most high risk, that means those patients would have qualified for more extensive and more costly, maybe sometimes invasive screening protocols. 11% of patients had intravenous contrast allergies. So they said that they need to go back to the drawing board and maybe rethink the screening procedures here. And I think that's a good strategy. Nonetheless, a lot of good bullets in this report in JAMA Dermatology. Breast cancer was the most prevalent, 9 out of the 18 patients, followed by lung and ovarian cancer. But those are common cancers, is that not? Half of them, the cancer occurred before the dermatomyositis diagnosis, the other half after. In looking at those who had cancer with dermatomyositis, those who didn't, TIF1 antibody positivity was more common, a third of patients versus 12%, but not MSA antibodies. And actually MDA5 or NXP2 were not necessarily higher in those with cancer. And I think that there's a number of other interesting points that make it a good read if you want to do that. My last recommendation or article talk about is from Annals of Rheumatic Disease, the EULAR Press Stills Disease Management Recommendations. These were presented at EULAR in 2023 by Bruno Fautrel and an expert consensus panel. What's great about these 14 recommendations is they do mirror sort of support the ACR guidelines on optimal strategy for treating patients with Still's disease or systemic JIA, meaning that they strongly endorse the early initiation of either an IL-1 or an IL-6 inhibitor. These recommendations stress the importance of identifying and treating aggressively both macrophage activation syndrome and the rare but serious complication of lung disease associated with Still's disease, which is still looking for some understanding, but the outcomes there are severe. There are 14 new recommendations. Here are, and again, if you're now tired of Cush talking about Still's disease, now go get a cup of coffee because I'm going to go into 14 recommendations, although it's going to take me a minute. So number one, I like this. I always talk about the Still's triad of being arthritis, polyarthritis, spiking fevers, and evanescent rash. I like their triad better. Spiking fever greater than 39, the evanescent rash, and a marker of high inflammation is necessary to consider the diagnosis of Still's. This is brilliant. Number two, if you should look for, if you have access to, IL-18 levels and S100 proteins, meaning calprotectin levels, but that's kind of a research tool, so I don't know that that's that important. Number three, it is important to exclude infection, neoplasia, other autoimmune or autoinflammatory disorders. Number four, it's important to identify clinically inactive disease, CID, which means that you have no still symptoms, but if you have CI and a normal SED rate in CRP, but if you have clinically inactive disease for greater than 6 months, boom, you now qualify as being in remission, on drug or off drug. They say that, and they also define targets for when you initiate your therapy, including like in the first 7 days, there should be no fever and a 50% reduction in CRP. By week 4, no fever and swollen joint counts down by more than 50%, so on and so forth. Number 5, that it's okay to use nonsteroidals, but use glucocorticoids acutely, but not long term, and then try to avoid them whenever you can. Number 6, if you're on steroids, you need to be starting an IL-1 or an IL-6 inhibitor ASAP. 1, 2, 3, 4, 5, 6. Number 7, 8. DMARD tapering is okay, but only after you've achieved clinically inactive disease off of steroids for at least 3 to 6 months. Next, you should be looking for MAS and the lung disease associated. You should always be suspicious of MAS. What is MAS suspicion? Let me get that for you here. MAS suspicion comes with rising ferritin. Really, I like when your CRP and SED rate are really high and your white count's really high, and all that sudden takes a dive, especially the CRP, and especially the white count. And then you have rising LFTs and super high ferritins and D-dimers and evidence of DIC. That's the definition of suspicion for MAS. If you have MAS, they endorse high-dose steroids, anakinra, cyclosporin, or emapalumab, the gamma interferon inhibitor that called Gamifant, that's actually FDA approved for HLH. Number 12, you should screen for lung disease in Still's disease. I don't know what that means, and I'm not really doing PFTs on people with Still's disease unless they have pulmonary symptoms or an abnormal chest x-ray. Then a further workup is necessary. Number 13 is if lung disease is present, the Still's disease complication of lung disease, that is not a contraindication to use IL-1 or IL-6 inhibitors. And that why they bring that up is because some have thought, the Stanford group has thought, that maybe this lung disease is a DRESS-like reaction, a drug allergy reaction to IL-1 or IL-6 inhibition, because many of those cases occurred in people on chronic IL-1 or IL-6 inhibitors, but recent, and along with a certain HLA haplotype, It turns out that that's not looking like that's the case. So it is okay to use an IL-1 or IL-6 inhibitor. And lastly, if a patient has difficult to manage Still's disease or this lung disease complication, they should be co-managed in consultation with an expert at a Still's disease referral center. I think that these are good guidelines, even though I have a problem with a few of them. I think that's really important for you to consider if you're managing patients with Still's. Again, I want to remind you that you can register for RheumNow Live 2025 in February at RheumNow.live. We'll see you in Dallas. Artie Kavanaugh and I have put together a program that we think you're going to love. See you then.